Okay, now let's talk about pain. So pain is a part of the somatosensory system, and the pain receptors that are the receptors that detect pain in the skin and other parts of the body are called nociceptors. Nociception is just a fancy word for pain, so that's all it means, just pain receptor. Pain is, of course, usually the effect of some sort of damage to the skin or some other tissue. So any force or deflection of the skin that would be enough to cause damage would usually activate one of these pain receptors. And of course, this is important because knowing that your skin or your body is being damaged will be useful for avoiding that damage. So nociceptors come in basically all of them have the same endings. They just are unprotected branched endings of these dorsal ganglia neurons. So the axons of pain receptors simply branch and distribute themselves throughout the skin or whatever body part they're in. They don't have any specialized corpuscles or coverings like the mechanoreceptors. And they usually have lots of branches, so they have wide receptive fields. There are basically two types of pain receptors. The A delta fibers, so they're receptors that are branched from the A delta axons, convey fast, kind of sharp feeling pain. And then C fibers are responsible for the slow, dull, kind of aching pain that you feel after an injury. Another thing that makes pain receptors different from touch receptors is touch receptors are almost entirely in the skin. So your skin is your primary organ of touch, but pain receptors are almost everywhere. Pretty much every organ in your body has touch receptors. So not just skin, muscle, bone, your digestive tract, your cardiovascular system. The only organ, in fact, that does not have any pain receptors is the brain itself. So your brain does not have, and the spinal cord does not have its own pain receptors. This is why actually brain surgery is usually done while you're awake. So brain surgeons, when they want to do something to your brain, will give local anesthetic to cut open the skin and the skull to expose the brain. But then once in the brain, if they need to remove part of the brain, for example, they don't need any pain medication or any anesthetic for that, because again, there's no pain receptors. Also, when doing brain surgery, it's good to know what part of the brain you're messing around with. So brain surgeons like to have the patient be awake so that before they cut out a chunk of brain, they can stimulate it with an electrode and ask the patient, what did you feel, or if to see if they move a certain part of the body, if their language is affected, for example, and then they can determine if removing that part of the brain would cause severe cognitive effects. Anyway, but otherwise, other than the brain, every tissue and organ in your body has at least some degree of pain receptors in them. The reason that there are the two different types of pain receptors convey different types of pain is because they have different types of axons. So we already talked about this, but the main axons that convey pain are the A delta and the C fibers, and those are the thinnest of the somatosensory afferent axons, and C fibers in particular are thin and have no myelin. So for that reason, they are also the slowest in terms of action potential conduction velocity. And the C fibers are, again, so slow that for parts of your body that are far away, the time it takes for a signal to get to your brain from a C fiber can be measurable. At 0.5 meters per second, it can take almost a second for a signal to get from, say, the bottom of your foot all the way to your brain. And of course, you've maybe even experienced this. If you've ever stubbed your toe, you may feel the pain in kind of two waves. There's this initial sharp pain that arrives first, and then later, again, perhaps as much as a second later, you'll feel this slow, dull, like and that's again the input from the C fibers. So nociceptors can also be classified by the type of stimulus or the type of pain they detect. Most nociceptors are not specific for different types of stimuli, so they're what we call polymodal. So they just about anything that will activate a touch receptor will activate a nociceptor, but some are specific. So some are just mechanoreceptors; they only respond to mechanical force. Again, this has to be force that's intense enough to cause damage or potentially cause damage to tissue. Some are thermospecific. That means they respond specifically to either high or low temperatures. And then some are responsive to certain chemicals, some of which are released from tissues or from cells within your skin or within the body itself, such as histamine. And these receptors are thought to be the ones responsible for itch. So when something itches, it may actually be one of these C fibers that is being stimulated by a histamine or some other irritant in the skin. So pain, again, is there to tell your brain that there's something wrong with your body. There's some damage or potential damage to the body. So anytime you receive an injury, there's going to be pain from that injury, but sometimes there can be pain even in the absence of any kind of injury. This is called hyperalgesia. So hyper means greater than, an increase of something. Algesia is just another word for pain. So just like an analgesic is something that takes away pain, hyperalgesia is either the increased sensitivity to pain, meaning that something that would normally cause a small amount of pain, or in fact no pain at all, would become painful, or reduced threshold for pain, meaning the amount of pressure or the temperature normally required to activate a pain receptor is reduced. And then spontaneous pain, meaning just pain for no reason whatsoever, no stimulus at all, and yet pain is present. This is, again, something that everyone has experienced. If you've ever broken a bone or had a cut, the pain from that injury lasts well after the injury itself occurs. And hyperalgesia is caused by a lot of things. It's kind of a complex network, but it's mostly due to the fact that when you damage any part of the body, you're damaging cells, killing cells, and so a whole bunch of chemicals end up mixed together that aren't normally kept separate. So for example, potassium ions. So we've already talked about how potassium normally is at very low concentration in extracellular fluid. This is why most neurons have a large negative potassium equilibrium potential. So if you cause damage to a tissue and kill cells, those cells' contents, the cytoplasm, will leak out and enter the extracellular fluid, so that will raise the potassium concentration in the extracellular fluid, which itself can activate pain receptors. Also, there are various hormones that get released from dead or damaged cells. Bradykinin is an example. Prostaglandins are hormones that are produced from cell membranes, or the lipids that form cell membranes. Those can activate pain receptors. If you've ever taken aspirin or another type of non-steroidal anti-inflammatory drug, so things like, again, aspirin or Tylenol, most of those work by blocking the enzyme actually that produces prostaglandins. But those molecules will activate the pain receptors, and then pain receptors themselves can actually create sort of a positive feedback loop that can increase hyperalgesia. So pain receptors can actually, when an action potential travels along a pain axon from the source of injury, normally it goes into the spinal cord, but then the action potential can actually travel backwards, essentially up other branches of that same axon. And pain receptors actually have the ability to release neurotransmitters peripherally, which is something that somatosensory receptors do not do. And so, for example, they can release this stuff called substance P. Substance P is an example of a peptide neurotransmitter. So that's a protein that's released like a neurotransmitter. Substance P does a lot of things. One of the things it can do is cause dilation of blood vessels. So this is one of the reasons why If you have an injury, it can start to turn red and to swell. That's because there's increased blood flow to that part of the body. And then substance P can also activate these immune cells called mast cells. Mast cells then, among other things, release histamine. Histamine itself can activate pain receptors, but then histamine can also trigger a whole series of reactions in the tissues that cause swelling, again, more blood flow and more redness. So anytime an injury is swollen and red, that's due to histamine. And all of this together just increases the sensitivity of those pain receptors. And the reason this happens, again, I mean, this is the molecular reason, but the advantage, the reason this is an adaptive response to pain is that it allows your body to not only know there was an injury, but to sort of keep treating that injured body part carefully. Because of course, if you've broken a bone or if you've had a bad cut, you want to keep that part of the body still and not bump it against things, because that will promote healing. If the pain only occurred when the injury occurred, then you would find yourself bumping your arm into things or whatever the body part was, and that would make it harder for the injury to heal. So hyperalgesia or inflammation is a mechanism for the body to kind of help heal itself from injury. But of course, it can go kind of haywire. So for extreme injuries or for hyperalgesia can be caused by things that have nothing to do with an injury. And so in those cases, you have increased pain or what's called chronic pain, and usually some sort of intervention has to be used. So that's why we take pain medications, usually to treat this sort of long-term pain from injuries. The central pathway for pain is similar to the central pathway for touch, but with some important differences. So again, the C fibers and A delta fibers, their cell bodies are in the dorsal root ganglia, and their central process goes in through the dorsal root, just like the touch receptors. But unlike touch receptors, they branch, but they don't have a projection that goes all the way to the brain directly. Now there's a branch you can kind of see here, where one central part of the axon does branch and goes along the spinal cord, but this is just for communication within the spinal cord. So this projection does not go all the way to the brain. This region that's right at the surface of the dorsal horn, called the zone of Lissauer. I think I'm pronouncing that right. But then the other branch of this axon synapses immediately onto neurons whose cell bodies are in the extreme dorsal horn of the spinal cord. This little chunk here at the edge of the dorsal horn is called the substantia gelatinosa. So these are interneurons in the spinal cord. That means that their axons do not ever leave the central nervous system, but their axons do come out and they actually cross to the opposite side. So they cross immediately from this is the right side of the spinal cord. They cross immediately to the left, and vice versa. And then their axons, rather than go up the dorsal columns, remember that the touch receptors project up to the brain through this region called the dorsal column. The pain receptors project through this more lateral white matter region in the spinal cord. So the projection to the brain for pain is separate from that for touch, and it follows what's called the spinothalamic pathway. And it's just called that because these dorsal horn neurons from the spinal cord, their axons cross over. They go up what's called the spinothalamic tract, which is just in the kind of ventral lateral part of the spinal cord. They go right through the medulla, so they don't synapse in the medulla. Remember that the touch receptors have relay neurons in the medulla in the dorsal column, but these go right past that and go straight to the thalamus. That's why it's called the spinothalamic pathway, because it goes straight from the dorsal root ganglia to the spinal cord to the thalamus. And in this case, it's what are called the intralaminar nuclei of the thalamus, which means they're neurons that are sort of in between other nuclei within the thalamus. But in any case, it's just a special part of the thalamus that processes pain information. And then those neurons do project to the primary somatosensory cortex, so it's the same part of the brain that gets input about touch, but there are just different neurons and different layers of the primary somatosensory cortex that process pain. And then, of course, just like with the body, just like with the somatosensory system, there's a separate pathway for pain information from the face. So your face sends pain signals to the brain through the trigeminal pain pathway. So the trigeminal nerve has its own set of pain fibers that enter the enter the brainstem and synapse onto neurons in the spinal trigeminal nucleus. And then they also go to the thalamus and then to primary somatosensory cortex and so on. So again, ultimately they end up in the same place, but they just go through different axons. So because there's a difference between the pathways that these axons take, there are some interesting differences in how information gets to the brain for pain versus touch. So this over here on the left, this is the dorsal column medial lemniscal pathway. This is the main somatosensory system that detects touch. So the input for this pathway, again, are the dorsal root ganglia axons that come from these A alpha, A beta, A delta fibers. Those are your main touch receptors. The A delta fibers also are pain receptors, but some of them follow this pathway, and they do not cross the spinal cord or the midline. Instead, they branch and go immediately up the dorsal column to the dorsal column nucleus. Dorsal column nucleus, neurons cross to the other side. Their axons cross to the other side where they synapse on the thalamus and then go to the somatosensory cortex. Pain receptors, also the temperature receptors, which we'll talk about in a second. Again, they come in through these A delta and C fibers. They synapse onto interneurons in the spinal cord, and the interneurons, their axons cross immediately and go up to the brain through the lateral spinothalamic tract, and they go straight to the thalamus, and then from the thalamus to the cerebral cortex. So within the brain, the anatomy is more or less the same, but in the spinal cord, the pathways are in slightly different places. This can lead to some unusual effects of certain kinds of spinal cord injuries. So, for example, if you were to have an injury to, let's say, the left side of the spinal cord. So if you had an injury right here that cut these axons on the left side, but not the right side, that would sever the axons that, again, take touch information from the left side of the body. But it would also sever those axons that are bringing in pain information from the opposite side. So again, if this is one of those interneurons that's getting pain information, those axons are going to cross over and they're going to go up through that same part of the spinal cord. So you would cut the touch receptors from the left side, but the pain receptors from the right side. So what that would mean is from this point down, so from where, let's say, if this is in the thoracic spinal cord, I don't know, then all the lower part of the body, the legs and the trunk, you would lose touch sensation on that side, on the left side of the body, but then you would lose pain information from the right side of the body on that from that point down. Meanwhile, the left side of the body could still feel pain, and the right side of the body could still feel touch receptors, because the pain receptors from the left side are going to cross over and presumably not be damaged. So it creates this sort of really unusual asymmetrical effects on pain and touch if you have these unilateral spinal cord injuries. In reality, those kinds of injuries are kind of rare. The spinal cord, for the most part, is not much thicker than your pinky. So the kind of injury that would affect one side of the spinal cord and not the other would be pretty unlikely. Most spinal cord injuries affect both sides. Now, pain is a little more complicated than touch in some ways. Pain receptors, we've already said, have more diffuse receptive fields. They cover a lot more parts of the body than just the skin. And then the way that pain is regulated by circuits in the spinal cord and the brain make it more complicated too. So for example, pain fibers exhibit something called afferent regulation. So when for some pain receptors, when they enter the dorsal horn, they most of them or all of them synapse onto these projection neurons, which are going to form the spinothalamic tract. But they also connect with interneurons, which are in the dorsal horn of the spinal cord, which are usually inhibitory. So these neurons would inhibit these projection neurons. So these pain receptors inhibit the inhibitory neurons, and that sort of amplifies the signal of the spinothalamic tract. But some of the touch receptors, the A alpha or A beta receptors from the skin or the muscle, that come into the same dorsal horn region, will also synapse onto the spinothalamic tract neurons, but more importantly onto these interneurons, these inhibitory interneurons. And the reason that is important is that if you activate the touch receptor at the same time as the pain receptor, the touch receptor will reduce the signal of the spinothalamic neuron. So it has a way of sort of inhibiting or reducing pain. And again, like I said before, normally for a lot of injuries, if you've damaged part of your skin or your body, you don't really want to have a lot of physical contact at that point because you'll cause more damage. But you've probably had an experience where if you've bruised your shin, then it might actually make it feel better if you sort of rub or apply pressure to the region around the injury if you're not directly pressing on the injury itself. And that's because of afferent regulation. So when you're doing that, you're sort of stimulating the touch receptors that are next to the injury, if not directly on it. And that has the effect of inhibiting the pain signal to your brain through this circuit. And then there's also descending input from the brain. So descending means something coming from the brain to the spinal cord. And there are several pathways from the brain to the spinal cord that regulate or sort of affect pain signals to the brain. So these regions of the brainstem, including the raphe nucleus, is in the medulla. It secretes the hormone, the neurotransmitter serotonin. And that in turn gets input from this part of the midbrain called the periaqueductal gray. That's what PAG stands for. It's called that because it's next to the cerebral aqueduct. So if you remember from the anatomy, we know that this little hole through the midbrain is the cerebral aqueduct. So that's why this is called the periaqueductal gray. But these neurons have axons that go to the raphe nucleus, which in turn project to the dorsal horn neurons of the spinal cord. And it's known that activity in this pathway can inhibit pain signals. And so the things that activate this pathway can vary. Actually, extreme pain, so pain from extreme injury, can be reduced by activity in this pathway. So this is why it's thought that sometimes you hear stories of people receiving severe injuries from, say, gunshot wounds, for example, and not feeling any pain when they initially are shot or hurt. And it's thought that this descending pathway is responsible for that. Importantly, another type of hormone that affects these neurons, especially these periaqueductal gray neurons, are called endorphins. Endorphins are called that because they're endogenous molecules that bind to what are called the opioid receptors. So opioid receptors are proteins that are found in some neurons in your brain that are called opioid receptors because they bind or are activated by extracts from the opium plant. So this is an opium plant over here, these little buds here that the flowers, it's basically sort of the fruit of the opium plant, secretes this liquid that has been known for many years to cause analgesic effects and some effects of euphoria, and that's because they contain molecules such as heroin that activate these opioid receptors. In fact, that's why they're called opioid receptors. And there's other substances that activate opioid receptors, morphine, codeine. These are all different medications that activate opioid receptors. They're used normally as pain relievers. So they work on pain receptors or pain pathways because they activate these opioid receptors, which in turn inhibits pain signals from the body getting to the brain. But of course, they also have the effect of being highly addictive. And so this is why, there is currently sort of or is a what's called an opioid epidemic going on, because these are, unlike say illegal drugs like say cocaine, for example, things like morphine and codeine. Those are legal drugs that doctors prescribe as pain medications, but a lot of people can easily get addicted to them even well after their whatever caused their initial pain had gone away. But anyway, that's how opioids work. They activate the opioid receptors, which in turn, at least in the pain pathway, inhibit information getting to the brain. Now, temperature is closely related to pain, so we'll talk about that next. The temperature receptors, which are called thermoreceptors, are actually some of the same receptors that detect pain. So these some of these A delta and C fibers that normally detect pain may also have temperature sensitive ion channels, and that's pretty much what it sounds like. So these are ion channels in the membrane of these axons that open and close depending on temperature. So some are heat sensitive and some are cold sensitive. So these receptors over here, these are the names of the receptors: TRP, V3, V4. These are all heat sensitive. That means that as temperature increases, so this is temperature versus channel activity. So these receptors all become more active, meaning they open at higher temperatures. Whereas these guys over here are more active at lower temperatures. So when you get down below this, say like 25 degrees, these channels start to open up. And of course, body temperature is usually in the low 30s. So this is degrees Celsius. So anything above that temperature will activate heat receptors. And of course, again, these are skin temperatures. So you have a separate set of receptors that are actually detecting the temperature of your blood flow that are unrelated to this. But these receptors, again, they depolarize the membrane and cause action potentials once they get below or above their threshold temperature. So again, the warm or heat receptors work between 30 and 45 degrees Celsius. And they're also sensitive to a molecule called capsaicin. So capsaicin is not a molecule that's normally found in your body. It's produced by certain plants, especially plants that are often thought of as peppers. And so capsaicin activates the warm receptors in your skin and other parts of your body, and they send a signal to your brain that your brain interprets as heat. So this is why peppers are called hot. They actually activate the heat receptors in your mouth, so the molecule is perceived as both spicy and actually hot because you're actually activating hot receptors. And then the cold receptors, which are activated at much lower temperatures, are also sensitive to a molecule called menthol. Menthol, again, is produced by certain plants, especially the mint plant. And again, this is why things that have a minty flavor are often thought of as having a cooling sensation, even though the actual temperature is not changed when you're exposed to menthol or capsaicin, but your perception of temperature is affected by it. Of course, we often add these substances to food. So if you like spicy food, you probably like capsaicin. But again, the capsaicin itself is not a flavor. So if we remember back, we talked about the gustatory and olfactory systems. So there are capsaicin receptors in your mouth and on your tongue, but those are not taste receptors. Your taste receptors can only detect those 5 things. So salty, sour, sweet, bitter, and umami. Capsaicin is not one of those. So the difference between the capsaicin receptors and the gustatory receptors is that the gustatory receptors, pretty much by definition, are only found on the surface of the tongue, whereas capsaicin receptors are found on your tongue, and in fact, the entire inner surface of your mouth, and in fact, even deeper tissues, tissues that are not anywhere near your mouth. So the lining of your eyes, for example, if you've ever cooked with jalapenos or any kind of pepper without gloves and then made the mistake of rubbing your eyes, you have learned a valuable lesson that you have capsaicin sensitive receptors in the tissue around your eyes. Same way with the nose. This is in fact why pepper spray works. So pepper spray is basically concentrated capsaicin solution, and so that gets into the eyes and the mucous membranes of the nose and it activates those receptors, which again are not just temperature receptors, they're also pain receptors. So that combination of heat and pain is what is the result of capsaicin activity. Also, by the way, there are capsaicin receptors at both ends of your digestive tract. So that's why food that is spicy when you're eating it, but it's also causes some degree of pain on the way out. Another important property of temperature receptors, just like with touch receptors, is that they exhibit adaptation. So they're not so much responsible for detecting absolute temperatures, but they're really important for detecting changes in temperature. So that's what's going on here. This is measuring skin temperature. So a change from 38 degrees to 32 degrees Celsius. 38 degrees is, like a pretty warm cup of water, perhaps. And so if you're measuring the response of a cold receptor, it has, these are action potentials coming from the receptor, and at 38 degrees maybe it has sort of some baseline activity, but then as soon as the temperature drops from 38 to 32, the neuron becomes much more active. You see this burst of action potentials, but over time, if the temperature stays at 32, that cell starts to become less and less active, and after a while it's almost as active as it was at 38 degrees. And then when the temperature goes back up, that's what really shuts that neuron off. This is a warm receptor under the same situation. So at 38 degrees it's active. When the temperature drops to 32, it goes quiet. But then what it really responds to is that change from 32 back to 38. So it's the increase in temperature that it's really detecting. So again, cold receptors, what they really react to is a drop in temperature, and warm receptors really react to a rise in temperature. But neither one really is particularly activated by any constant temperature. And again, this is something you've probably experienced. You experience every day. So if you go outside, maybe not right now, but if you were to go outside when it's cold and then come back in, you would notice that the temperature feels a lot warmer than it did before you left, even if it hadn't changed. And so when you first go outside, the air feels very cold, but after a few minutes you find yourself sort of getting used to it or getting accustomed to it. That's because of adaptation. The cold receptors on your skin sort of become adjusted to the lower temperature. This is also why, again, if you've been outside in the cold for a long time and then you come inside and say put your hands in water, try to wash your hands, then even if you're using room temperature or even what you would otherwise call cold water, it might actually feel hot because your hot receptors are really detecting that sudden increase in temperature, even if it's an absolute temperature that would be below what you would consider warm. So again, this is just another example of adaptation in a sensory system, and it's a mechanism for really detecting those changes more than absolute levels. All right, that does it for the somatosensory chapters. So thanks for listening.